talk on lung transplantation for COVID-19, the who, what, where, when, and why. May I invite the speaker, Dr. Sandeep Attawar. May I also invite the chairpersons for this talk, Dr. A.G.K. Gokhale, Dr. K.S. Nayak, and Dr. Unni V.N. Over to the chairpersons.
Good morning, everyone. On behalf of my co-chairs and myself, let me thank the organizers for having invited us.
Thank you, Dr. Nayak. Thanks to the organizers. It's my pleasure to be here to listen to the talk by Sandeep Attawar. As we all know, Sandeep Attawar has contributed enormously to the lung transplantation program in this country. In fact, he has done a few hundreds of these, and today people like him and Bala have taken our thoracic transplant program to a peak, so that the world looks at us that we are doing some work. And he's at Hyderabad now. He shifted from Chennai. He's founded the transplant program at KIMS, and he's doing a wonderful job there. So I request Sandeep Attawar to go ahead once the other co-chairpersons talk about this.
To thank the society for this opportunity to speak here today about lung transplantation for end-stage COVID lung damage. A lot of what I'm going to speak about has come from a lot of experience that our team has gained in the process of transplanting numerous individuals with end-stage lung disease who are transferred or referred to our center. This is also an assimilation and an accumulation of their knowledge and understanding, and also the worldwide data that is increasingly appearing in the treatment of these patients. We know that the COVID pandemic has caused acute lung injury in millions of individuals worldwide. Many critically ill patients, once intubated, cannot be liberated from mechanical ventilation, while many others might develop post-COVID fibrosis, resulting in significant disability and the need for long-term supplemental oxygen. In both these situations, treatment teams often inquire about the possibility of lung transplantation. In fact, lung transplantation has been successfully employed for both COVID-associated respiratory disease syndromes and post-COVID lung fibrosis in a limited number of patients worldwide. Lung transplantation after COVID infection presents a number of unique challenges that most transplant programs must consider. This presentation underscores a few important concepts that help unpack the options that we as transplant physicians face, and ones that something teams must consider while deploying this therapy. So I'll now take the opportunity to probably share some insight on who are those patients who are indicated for surgery, when, where, and why. These are the ravages of COVID-19 visible on a recipient's lung who underwent a double lung transplant, a 19-year-old individual. We would like to call it the hepatization of the lung. The changes are innumerable and the destruction is simply unimaginable. If you're looking at lung transplantation for COVID ARDS, I think there's enough published evidence now, and there's a mountain of data turning up every time that we look at publications. But there was this seminal paper by Shaf Kechevji and Marcelo Saipel from the Toronto group, which clearly laid out in the Lancet indications for lung transplantation for COVID-19, where they said age was important. A fit individual less than 65 years of age as far as possible with single organ dysfunction, having allowed them sufficient time for lung recovery with clear radiological evidence of irreversible lung disease, where the patient and the family are spoken to and they're able to discuss the option of transplantation as a rescue option. Patients would be on a rehab program while waiting on the transplant wait list in the ICU. They should probably also fulfill the remaining transplantation criteria like BMI and not excessive comorbidities with recent SARS-CoV negative tests, at least 2 deep bowel samples which show lack of infectivity. In a transplant center with substantial experience of high-risk transplantation, provided we have a broad donor pool with the center demonstrating low weight risk mortality for equitable organ allocation. If you're looking at the current status, number-wise, UNOS came up with some great data in the middle of this year. They said that 78 double lung transplants were done for COVID, 50 of them were for COVID ARDS, and 28 of them were for chronic COVID pulmonary fibrosis. The Eurotransplant showed a significantly lower number. They had done probably around 18 by that duration in the first 4 months of the year. At our center at KIMS in Hyderabad, we've performed 27 double lung transplants for COVID-destroyed lungs since till September 21. So the question is, why are these numbers low? The reasons are multifactorial, and most of them are because hospital and healthcare systems are inundated and not many resources could be diverted, not just for the assessment, but also for the follow-up of many of these patients who could potentially turn up for transplantation. Data was inadequate. New disease needs new data to be able to decide the right indication and the timing. And there were many patients who had significant contraindications for transplantation. Over and all about this, transplant programs had generally dialed down their numbers close to limbo, and donations were down. So when you start approaching the evaluation of COVID patients, there are two sets of patients. One of them are these ones who follow up in the outpatient with high oxygen demand, who are waiting for a lung transplant, and then the others are obviously inpatients who are critically unwell. The strange part is that this virus will forever change the landscape of fibrotic ILD. How the virus will interact with pre-existing ILD or on a specific phenotype is currently only conjecture. Time will tell us exactly how this happens and what will be the clear-cut indications. It will probably take a couple more years for us to realize that. But the most important fact is COVID causes or creates a fertile ground, like a burn pit in the lung, which can probably predict that lung for future ILD. Currently, the listing criteria for COVID fibrosis matches those of fibrotic ILD, and we know that as new data emerges, we'll have better information. We'll be more guided in our decision making. However, the silver lining seems to be that in many cases the fibrosis seems to be regressing, and that's a great sign. So that tells us that probably not all of these patients will probably require a transplant. But as more and more greater data is generated, there'll be greater clarity and lesser granularity. If you're looking at the natural history, the decisions of lung transplant hinge on the natural history of the disease, which we discussed, but there are certain risk factors for severe disease. Most of them are advanced age, obesity, additional medical comorbidities, pre-existing lung disease, prolonged ICU stay, prolonged ventilation and barotrauma, a history of alcoholism, a previous smoker, or probably someone with a genetic predilection for ILD. The pathogenesis is still unclear, but it's believed that the virus induces pro-fibrotic pathways through the renin-angiotensin system and also creates the activation of growth factors, causes direct cellular injury both to the endothelium, alveoli, and macrophages are activated, leading to gross fibrosis in and around the alveolar apparatus. Unfortunately, mechanical injury induced by barotrauma also triggers fibroblasts locally, creating fibrosis at a different level. The evaluation of these patients obviously requires proper history taking for not just occupational exposure, but symptoms and signs. But past or baseline records of these patients would generally be greatly helpful to be able to realize or understand how COVID would have impacted most of them. It's important to also know that most of these patients have residual PTSDs, anxieties, residual depression after a long hospitalization. It's vital to make sure that we address these issues. Most of these patients have been exposed to chronic hospital stay and thereby are nutritionally imbalanced. They need a lot of pulmonary and physical rehab with nutritional enhancement. Eventually, when you're looking at lung transplantation as the last recourse, it's important that the family and the patient are taken through an all-round psychological and family counseling in order to consent for a lung transplant. The situation with patients who are admitted is slightly different. Unlike ambulatory outpatient COVID pulmonary fibrosis, there are two unique phenotypes in the patients who are in hospital. The important part is the ones that are on mechanical circulatory support and mechanical ventilation, and the others being in high dependency units with a large amount of oxygen intake. It's very important to understand that the dilemma lies in figuring out whom to transplant and whom to wait for potential recovery. And that's still a challenge that most of us continue to grapple with. The problem is that if you wait beyond reasonable measure, further deconditioning can happen, secondary infections can set in, and serious complications can vitiate a good outcome in the long term. So we must realize that every case is unique, and center experience is crucial to outcome. So whenever you perform a procedure, it's important to also look at resource allocation and center experience. The last point I would like to make here in this slide is that lung transplantation by nature is triage medicine, and the likelihood of a successful transplant has to be weighed against societal need and organ justice in the setting of paucity of organs. So it's important to also know whether the recipient that you're planning for a transplant has any traditional contraindications for transplant. Most of them are the ones that we have for standard transplants. But importantly, in these situations, it's vital to know that the organ dysfunction has to be singular. Besides, there should be no irreversible neurological dysfunction. And in the long term, these patients should not have had any issues with following a complex medical regime post-transplant. They should never have had addictions in the past that or complex psychiatric illnesses, which could create trouble in the long term and affect long-term survival. One of the important questions that is difficult for us to gauge is that is this lung injury reversible? Now that needs input from many team members. We need adequate time for recovery. We need to maintain best practices with in ICU care and lung protective ventilation. It's vital to know that patients who have at 8 weeks who have traction bronchiectasis and irrefutable subpleural fibrosis are pointers towards irreversibility. A review of CT scans is vital. Many a times it helps us figure out and gives us a snapshot of time on a timeline, letting us know whether there have been secondary causes like bacterial infections, which could have been treatable or would have vitiated the current clinical picture. All of these issues should be addressed and looked into quite closely before we eliminate all of them, before committing to the final step in the decision-making tree. It's also vital to know whether the patient has cleared COVID-19, and we have standard criteria for this. It's important to also understand that if we have inadequate COVID clearance, it could not just risk the team, but it would also confuse the picture of graft dysfunction in a post-transplant situation, which could lead to a lethal or an unfavorable outcome. It's vital to also know if the patient is physically conditioned for a transplant. We know that most of these patients have critical illness neuropathy, and it's caused by prolonged hospitalization, excessive neuromuscular blockade, sometimes caused by steroid-induced or drug-induced myopathy, and waves of infection. So aggressive rehabilitation, nutritional enhancement, maintaining them awake, making a constant effort to recruit the lung, maintaining the respiratory drive, trying to reduce fragility to a great extent, discussing with the family regarding support and mental preparedness for long-term compliance is very important. The question about dual organ transplantation turns up when you have patients with AKI, and we know that a significant number of patients with COVID-19 have been admitted and require some form of renal replacement therapy. It's important to know that double lung transplant could be performed in someone with renal dysfunction because renal replacement therapy could be continued in the post-operative period. However, the risk of the transplant would be higher. At this point in time, a dual organ transplant, that's a kidney and a lung, are generally not considered unless the patient has had background CRF before having COVID lung damage, and they should be reasonably good candidates and well built or reasonably in good health to be able to undergo a double lung transplant. There are a few peripheral issues surrounding COVID which can affect transplants, and there's a relaxation in the rules regarding the negative pressure OR if the recipient is nucleic acid tested negative. Standard protection may not be needed. Aerosolization can be minimized using energy coagulators. The chest entry is generally very hostile because they have been on ECMO for quite some time. They have vascular adhesions, loculations, drains that need to be looked into. There are air leaks. Many of them have empyemas. So it's vital to know that all of these can negatively impact the operation. Eventually, there's an intriguing possibility of a single lung in chronic COVID pulmonary fibrosis, allowing the rare chance of the contralateral lung to recover on its own. We must also gauge the effect of physical deconditioning and critical illness neuropathy, besides the effect of stress injury to secondary organs when you're looking at a transplant in some of these patients. Some other issues would be an inundated blood bank because the surgical blood loss can be excessive. Thereby having enough reserves is very vital. Most of these patients are immunologically active. and we have a very short window to desensitize them, and that becomes a challenge in a transplant. Induction agents can be used, but have an increased risk of causing infection in the post-operative course. Only high acuity centers should perform these procedures, and the long-term focus on rehab and surveillance is monumental. Thereby, a great deal of focus has to be paid to that. This is our experience at KIMS Hyderabad with double lung transplants for COVID destroyed lungs. We've done 27 cases now. We have had 19 survivors. These are the breakdown of the data. So in the end, while we sum up everything that we've discussed, we're looking at some evolved selection criteria. And when we consider that, we could say that a patient could be considered for lung transplantation if, in spite of mechanical ventilation or long-term ECMO support of more than 4 or 6 weeks, and there is no clinical improvement. Yes, this is one area where we should pay serious attention to. There's a persistent diffuse infiltrate on chest X-rays or an evidence of pulmonary fibrosis on computerized tomography affecting almost all the lobes. If the compliance consistently stays below 20 ml per millibar, if there are infected pulmonary cavities and the development of unmanageable pulmonary complications, if we have established or clearly suspected thromboembolism with significant secondary pulmonary hypertension and a recurrent reappearance of right ventricular dysfunction, I think these are standard accepted criteria that would allow us to deploy lung transplantation in patients with advanced life support.
Sandeep, sorry to interrupt. Are you with us now?
So in the end, I would like to thank you by saying that we're all going to see COVID hills and valleys, at least for the next few years, as we get more and more vaccines available in the market. We all know that this is going to help. But I can only tell you this, that in this coronavirus forest fire, nothing will stop until it finds all the human wood that it can burn. Thank you very much.
Thank you. I'm sorry we have run out of time. Is there a quick comment from Dr. Gokhale or Dr. Nayak? We need to close now.
Yeah, I think that is an excellent presentation. At least because of this COVID, I would say the positive side is people are aware of lung transplantation. We had a lot of difficulty in pushing people to lung transplant before. Now the awareness of lung transplantation has gone up. I guess in future we'll see more and more work being done by people. Thank you. Thank you, Sandeep. Excellent lecture.
I fully agree. I think people like you are going to save a lot of lives in case we get the third wave. We are prepared now. Thank you for an excellent talk. And thank you, Dr. Unni, for joining in. And thank you, Dr. Gokhale.
Thank you.
I thank the speaker and the chairpersons for this talk.